Good morning, everyone. It's 9 a.m. I guess we'll go ahead with the session. A couple of our speakers are yet to log in. Ms. Saujanya, do you have any information on the speakers?
No, doctor, not yet.
We won't wait. We won't wait. We'll go ahead. We don't want to waste time.
Okay,
So,
doctor.
welcome everybody and a very good morning to this glaucoma symposium in COSCON 2021. Although it's titled Glaucoma Medications, I don't see any topics on glaucoma medications. So, let's just call it glaucoma evaluation. We have Dr. Tanushree Hegde with her topic, that is IOP measurement tips and tricks. Doctor, will you be presenting live or do we have a recorded?
Hello, sir. I have
Yes.
already sent my presentation.
Yeah, what would you prefer? Play?
Yeah, I will share, doctor.
No, what would Dr. Tanushree prefer? Play it or you want?
Yeah, you can play it, sir.
Okay, so
You
then
can
you
play
go
it.
ahead and play it. Yes.
Hello, everyone. At the outset, let me thank the organizers for this opportunity. I'll be talking on IOP measurement in terms of certain do's and don'ts. As we know, intraocular pressure is a major risk factor for the development of glaucoma, as well as the only significant treatable risk factors when it comes to reducing the risk of progression of the disease. So, accurate and precise IOP readings are very imperative to make a proper treatment and management decision. We'll see how to measure IOP and certain practical implications in critical settings. Coming to how to measure IOP, direct IOP measurement can be done using manometers, but they are not very feasible in day-to-day, practically feasible in day-to-day practice. So we have certain calibrated instruments which make quantitative assessment of the IOP in indirect manner, and there are many types based on their principles. And the most common, as we know, is the fixed area static contact applanation tonometers, that is the Goldman, Perkins, Tonopen, etc. So we have to have a consistent, reproducible, and a reliable technique of tonometry, which is convenient to use, simple to calibrate, cost-effective, and free of maintenance issues. Goldman applanation tonometer fits the bill. It has been the gold standard since its introduction in 1955. It's based on Eimbert-Fick law, which states that the pressure inside an ideal sphere is equal to the force required to applanate the surface divided by the surface area. But when it comes to cornea, the corneal resistance and surface tension of the clear film have a practical influence on this. And to negate this influence, the prism has been given a diameter of 3.6 millimeter. The Goldman applanation tonometer is basically a slit lamp mounted instrument with a biprism and a tension dial. The technique is also fairly simple, though it has a short learning curve. Done under topical anesthesia with fluorescent staining of the tear film. Cobalt blue light is used to illuminate the cornea and the biprisms. It has to be done at low magnification with the maximum beam length and width. Light source and the optics are angled at 60 degree, and keeping the dial position at 1, we have to advance the biprism until it just touches the apex of the cornea. At this point, the contact surface of the cornea is converted into two fluorescent semicircles which are viewed through the biprism, and then we have to adjust the dial until the inner edges of these two semicircles just touch and look for the ocular pulsations. This is the end point. At this point, we have to take the dial reading and multiply by 10 to get the IOP measurement. As you can see in the first figure, this is the correct alignment of the fluorescent ring seen in the regular cornea. And in the astigmatic cornea, we'll see slightly irregular Meyers. When the dial reading is not proper, we will have this unaligned Meyers and we have to rotate the dial accordingly. We will get thick Meyers when there is too much of fluorescent, giving a false reading. Also thin Meyers when the fluorescent is too less. We should have an appropriate thickness. It is said that at least the appropriate thickness of the Meyers is at least 1/10 of the diameter of contact. And when the probe height is not proper, we'll have such asymmetric Meyers. It's important not to do the GAT in presence of active corneal disease or injury or in case of epithelial defects. Do consider patient's position, comfort, and clothing because breath holding, Valsalva tight clothing may increase the IOP. Don't apply pressure on the globe. Do appropriate use of fluorescent stain. Too little fluorescent can cause thin Meyers and a falsely low IOP. Similarly, too much fluorescent can give thick Meyers and a falsely high IOP. Also, don't forget to take into account astigmatism. For every 1 millimeter error occurs for every 4 diopters of astigmatism. We see with the rule astigmatism underestimates the IOP, and against the rule astigmatism overestimates the IOP. So when astigmatism of more than 3 diopters is there, we can align the red mark on the prism with the axis of the minus cylinder. Or also, what we can do is we can take the measurements with the prism in vertical and in the horizontal axis and take an average of the two to get more accurate readings. Central corneal thickness is very important when considering the Goldman affiliation tonometer results, especially in case of NTG and ocular hypertension. This Goldman was initially designed to give accurate readings for a central corneal thickness, that is CCT of 520 microns. Though there are not specific nomograms available, you can always classify the cornea into thick, thin, and normal. And remember that thin corneas underestimates the IOP and thick corneas overestimate the IOP. GAT is not accurate in irregular corneas, and we have to calibrate the tonometer and sterilize the prism. Perkins applanation tonometer is similar to GAT, only thing it's portable, handheld, and henceforth it's useful in infants and children, can be used in OT and in recommend positions, and important to note it's comparable to GAT in accuracy. Tonopen is again a handheld small electronic device based on Macular principle. It takes 3 to 6 readings, which the plunger in the tonopen, it assesses the corneal resistance in the form of electrical waves, which is then converted into IOP reading by a microprocessor. It has a disposable latex tip cover. Important thing is it's not affected by astigmatism. It can be done over the soft contact lens also. It's very helpful in screening in case of corneal opacity, scarred cornea, edematous cornea, in oil-filled eyes and in children. It correlates, the readings correlate with the GAT in normal IOP ranges, but it tends to underestimate the GAT IOP in higher ranges and overestimate in lower ranges. Rebound tonometer, that is the eye care, is a very popular device nowadays, and it's a very useful tonometer, portable, handheld, no anesthesia is required. It can be done in any position in the newer eye care tonometer. Hence, it's suitable also in children and non-cooperative patients. It has a small metal probe, which is plastic tip, which rebounds on the cornea, and the induction current that's created in the rebound process is then converted into IOP. It's important to note the readings are very comparable to GAT. Only thing in thick corneas, it can give a slightly higher IOP readings. Then we have the non-contact tonometer, where increasing intensities of air puffs are used to apply the cornea, and the force required to flatten the surface is noted. It is fast, easy to operate, no anesthesia is required, but the readings are not very accurate when compared to cataract. And in the present scenario, in the COVID era, since it's aerosol generating, it's not very safe. Then we have newer tonometers like the dynamic contour tonometer, Pascal, which is slit lamp mounted. It is not CCT affected, and thus contour matching of the cornea instead of applanation. It can be the future standard. Only thing, it's not very useful in irregular corneas and takes longer time to test. We also have the ocular response analyzer, diatom transfer palpebral tonometers, Corvis ST based on the Shimflux technologies, which are all novel devices. Then we have 24-hour IOP monitoring contact lenses or implantable microsensors. This we are not discussing in detail since they are not very popular right now in the private practice, maybe because of their cost or availability. And what about the old techniques? Are they still relevant? Indentation tonometer, that's a SHORS, is still relevant because it's portable, affordable, simple to use, and it's still in use, very much in use in several medical colleges and helpful in camp screening. Only thing is, it is affected by the scleral rigidity. Hence, it can give a falsely high or low reading, and it has to be employed as a reserve technique when other instruments are not available. What you can do to improve the accuracy is you can take readings with two weights, that is 5.5 and 7.5, and then take an average of the two to get better results. Digital tonometry is not very accurate, needs experience, but it may have a role to play in case of flat AC in patients with keratoprosthesis and corneal infections. What are the practical implications of IOP reading in clinical settings? We should remember several factors influence the IOP and also several food and drugs. Keep in mind while doing an EUA in a child under general anesthesia. So a single IOP measurement above the expected average has little merit, and the role of IOP in the diagnosis of glaucoma is different from its role in treatment. Always determine the CCT. Always note the time of the day with each IOP measurement. Since 24-hour IOP monitoring may not be practically possible, you can schedule the office visits at different times to assess the IOP fluctuations in cases of progression. Very important to remember, the measurements obtained by different methods cannot be compared. That is, the tonometer readings are not interchangeable. The same method should always be chosen when you are doing a routine IOP control. And as you can see from the screen, special situations warrant specific tonometer use. This is a recent review article showing some guidelines and recommendations of tonometry in COVID era. As you can see, aerosol generating APE of tonometry, pneumotonometry are not recommended. Rebound eye care tonopen are recommended, and GAT has to be used with caution and especially with disposable prisms and slit lamp guards in place. To summarize, IOP check is a must in all patients. A single IOP reading should not be relied upon for diagnosis. Do measure the IOP before gonoscopy. Goldman application tonometer is still the gold standard. Rebound tonometer, tonopen are reliable, particularly useful in certain special situations. Results of the tonometers are not interchangeable for monitoring. Always follow a same method. CCT has to be considered as the most tonometry methods are still CCT dependent, and not to forget, we have to maintain sterilization of the instruments in between two patients' use and also follow COVID appropriate behavior in the present scenario. Thank you.
I think that's the wonderful presentation, Dr. Tanushree. Are there any questions for Dr. Tanushree? If not, then I'll request the moderator, Dr. Vikram Jain and Dr. Kamla Mahesh ma'am, to allow me, if it is possible, to talk a bit earlier.
Yes, Dr. Balla. Yes, you are the chairman. Yes, definitely. Your talk will be next, followed by, we'll go in by the order next. You can,
Right.
I request the speakers to stay until the end of the sessions. If we have any questions coming in from the audience, which will be passed on to me, I'll then ask the questions from the audience and we'll have a discussion at the end. Over to Dr. Balla.
Thank you.
Thank you, Dr. Vikram. So I'll just, can I share my screen? It is what I'm seeing is host disabled participant screen sharing.
Saujanya, can you do the needful? Dr. Balla would like to
Yes, Dr.
share his
Yes.
screen. Yes.
Yeah. Good morning, everyone. At the outset, I'm thankful to COSCON and Dr. Ellen Kumaran for giving me this opportunity. The topic I'm going to cover is the role of ocular perfusion pressure in glaucoma. As we all know, glaucoma is a progressive optic neuropathy of unknown origin, and traditionally the diagnosis and treatment has been directed towards the control of raised intraocular pressure, which is the most important modifiable risk factor. But some glaucoma patients continue to progress despite medical lowering of intraocular pressure or at IOP in the low teens in normotensive glaucoma. Various trials have shown that glaucoma progression occurs despite IOP reduction. Thus, elevated IOP may contribute to glaucoma pathophysiology, but may not explain the disease process entirely. And so other contributing factors may exist. In short, glaucoma is a complex disease that cannot be controlled by only IOP-reducing therapies in all patients. Glaucoma, in fact, represents a spectrum where mechanical damage causes damage at high intraocular pressure and vascular factors cause damage at lower intraocular pressure. But both these factors are interrelated, as increase in IOP decreases the ocular blood flow and vice versa. It has been found that 60 to 80% of the glaucoma patients have vascular insufficiencies. So managing IOP alone may not be sufficient to control progression, and there may be need to manage ocular perfusion pressure also. Way back in 1922, Felix Legrand noted that glaucomatous eye may represent a sick eye in a sick body. And we have historical perspective to the etiopathology, where vascular factors have been incorporated in the pathogenesis of glaucoma. As far back as 1800, von Graffe recognized the presence of glaucoma, which is not related to high intraocular pressure. Then in 1858, Jaeger, 1885, Smith also suggested involvement of both mechanical and vascular factors. Let us talk about these factors, non-vascular and vascular factors. The non-vascular factors may be IOP fluctuations, and other factors are age, female race, the Afro-American, the black races, family history, genetics, myopia, and decreased central corneal thickness. Vascular factors may be diabetes, systemic hypertension, migraine, disc hemorrhage, systemic hypotension, and low perfusion pressure. Aging causes reduced ocular blood flow by virtue of the fact that choroidal thickness decreases from 200 micron at birth to 80 micron at age of 90 years, which leads to reduced ocular blood flow. 47% of glaucoma patients also suffer from hypertension, and hypertension causes small blood vessels damage, and also the factor that antihypertensive treatment may also cause periods of nocturnal hypotension, which in turn decreases ocular blood flow. Migraine causes decreased ocular blood flow by the reason is that there is elevated levels of endothelin, which is a very powerful vasoconstrictor, and 30% of the glaucoma patients also have diabetes as coexisting morbidity, and it causes vascular damage and in turn reduce ocular blood flow. So in glaucoma patients, decreased blood flow has been reported to occur in the optic nerve, but also in retina, choroid, retrobulbar vessels, brain, and peripheral vascular system. The primary insult appears to happen at the optic nerve head, and increased intraocular pressure and ischemia at post-laminar optic nerve head affects retinal ganglion cell axons. And secondary insults may happen if ocular perfusion pressure falls below the lower limit of autoregulation, or in turn, if neurovascular coupling fails. So let's talk about vascular dysregulation. Vascular dysregulation occurs and it leads to disturbed balancing process between BP and IOP, which leads to decreased ocular perfusion pressure. And vascular dysregulation also leads to oxidative stress, which leads to apoptosis of retinal ganglion cells, and vasospasm may also occur in normotensive glaucoma patients, which may trigger daily episodes of hypoxia, reperfusion, injury. So if we talk about the etiological factors, which are risk factors for in glaucoma, these are all, besides increased intraocular pressure and IOP fluctuation, abnormal autoregulation, reduced ocular perfusion pressure, and fluctuation in ocular perfusion pressure, may all these factors in collaboration may lead to decrease health of the retinal ganglion cells, leading to retinal ganglion cells apoptosis and cell death. World Glaucoma Association 2009 gave consensus that ocular blood flow is very important in cases of glaucoma. So low ocular perfusion pressure has been identified as an independent risk factor for glaucoma progression. But do we have adequate evidence to justify routine assessment of ocular perfusion pressure in all our glaucoma patients? In other words, is OPP a modifiable risk factor? Recent studies have found low ocular perfusion pressure to be a risk factor not only for development of open angle glaucoma, but also for progression of glaucoma. So how do we find ocular perfusion pressure? Blood flow in any organ is the difference between arterial blood pressure and venous blood pressure. In case of eye, venous pressure is considered equivalent to intraocular pressure. So mean ocular perfusion pressure is mean arterial pressure minus IOP. And how do we derive mean arterial pressure? This is diastolic pressure plus 1/3 of pulse pressure. And ocular perfusion pressure is 2/3 of this mean arterial pressure minus intraocular pressure. So ocular perfusion pressure, the low systolic ocular perfusion pressure, low diastolic ocular perfusion pressure, all can be causative factor in development of glaucoma. Low diastolic pressure low diastolic ocular perfusion pressure less than 50 millimeter of mercury was associated with OAG prevalence in epidemiological studies which were conducted in countries like USA, Europe, and Caribbean. 5 major epidemiological studies have provided data on the relationship between BP, ocular perfusion pressure, IOP, and glaucoma. And these studies are Baltimore Eye Survey, Agna Newmark Study, Pro-October, Los Angeles Latino Eye Study, and Barbados Eye Study. All gave us the conclusion that decreased diastolic perfusion pressure between 1.9-fold to 6-fold causes there's risk factor, the decrease diastolic perfusion pressure less than 30 in Baltimore Eye Survey and less than 60 in Agna Newmark Study caused various folds increase in development of glaucoma. Let's talk about these studies one by one. In Barbados Eye Study, all perfusion pressures, whether it's systolic, ocular, or mean perfusion pressure, were associated with increased risk of glaucoma incidence. In Rotterdam Study, lower mean perfusion pressure was associated with increased risk of glaucoma incidence. Agna Newmark Study also, and there was some other studies also which were published later on, which established role of ocular perfusion pressure in glaucoma. Early management of glaucoma trial said with baseline IOP less than 21 millimeter of mercury, systolic BP less than 60 millimeter mercury was associated with progression, while in patients with higher baseline IOP, systolic BP less than 125 was associated with progression. Los Angeles Latino Eye Study said when systolic BP is too high, how does high blood pressure decreases ocular perfusion pressure? The vessels become arteriosclerotic. This leads to decreased perfusion pressure. And when diastolic blood pressure is too low, then it leads to decreased perfusion pressure, leading to optic nerve damage. This study also published in 2006 suggested that in persons without glaucoma, diastolic BP less than 90 millimeter of mercury resulting from antihypertensive treatment was associated with increased cupping and decreased rim area of the optic disc. So we have to be careful about the fact that antihypertensive treatment in open angle glaucoma patients may also lead to decreased diastolic blood pressure and decreased ocular perfusion pressure. So lowering of blood pressure with antihypertensive treatment is associated with increased risk of glaucomatous structural damage. Low pressure glaucoma treatment study, Barbados Eye Study, Rotterdam Eye Study, all gave us this conclusion. Blue Mountain Eye Study gave conclusion that 77% greater risk of developing glaucoma in patients with narrowed retinal arterioles. So what is the relationship? The first hypothesis is that subjects treated for systemic hypertension experience larger reductions of nocturnal BP, which leads to very low ocular perfusion pressure compared to subjects not on antihypertensive. And second hypothesis is that antihypertensive treatment disrupts the vessel's natural ability to auto-regulate at any given ocular perfusion pressure. So BP is a major factor which can affect ocular perfusion pressure. Early management of glaucoma studies suggested that early open angle glaucoma plus high baseline BP causes threefold increased risk of progression of glaucoma. Nocturnal decrease in what happens in the early morning. There is nocturnal decrease in blood pressure, plus increase in intraocular pressure, and this combination can have deleterious effect on optic nerve head. And we also should be careful, suggest to the cardiologist or to the physician that aggressive lowering of blood pressure should not be done, which particularly the drugs which cause nocturnal hypotension like calcium channel blockers may be avoided in this group of patients. Weinreb said that diastolic blood pressure has a greater effect than systolic blood pressure in calculating mean ocular perfusion pressure. And Greenfield quantified this relationship, suggesting that 10 millimeter change in systolic BP causes 2.2 millimeter mercury change in mean ocular perfusion pressure, whereas similar change in diastolic blood pressure causes 2 times, that is 4.4 millimeter change in mean ocular perfusion pressure. See, in patients with normal BP and autoregulation, a much greater rise in IOP would be required to compromise optic nerve head blood flow, because here autoregulation is effective. But in patients with hypotension and defective autoregulation, even normal IOP may compromise optic nerve head blood flow. Just like intraocular pressure, ocular perfusion pressure also has circadian rhythm. Why? Because both the parameters used in calculation of ocular perfusion pressure, that is BP and IOP, they exhibit circadian rhythm. So ocular perfusion pressure also has circadian rhythm. Fluctuation in ocular perfusion pressure has now been found to be a risk factor for progression in normotensive glaucoma, and increased mean ocular perfusion pressure fluctuation was proportional to advanced structural and functional damage in NTG patients at initial evaluation. And advanced glaucoma intervention study gave us conclusion that 1 millimeter mercury decrease in mean ocular perfusion pressure was associated with 0.23 increase in AGIS score and 0.53 decrease in TISNET average score. These are various studies which have been published, which have given us conclusion that OPP fluctuation is also an important risk factor for progression in glaucoma. So increased nocturnal IOP plus relative nocturnal hypotension would predict a substantial decrease in nighttime ocular perfusion pressure. In glaucoma patients, OPP is lowest around 7 a.m. just before awakening, when IOP is highest. How to measure optic nerve head blood flow? There are various equipments, but it is not very easy, and there are a lot of problems, and it is not a, we don't still have a gold standard. There are various instruments which can be utilized to measure ocular perfusion pressure are color Doppler imaging, transcranial Doppler, laser Doppler flowmetry, MRI, pulsatile ocular blood flow. And these are the various instruments which can be utilized. But these days, OCT angiography is, there are a lot of publications which can really quantify and measure the optic nerve head blood flow, both at superficial and deeper levels. This is the color Doppler imaging of central retinal artery, where we can calculate the peak systolic pressure and mean diastolic pressure, and this can really help us to find in various blood vessels, ophthalmic artery, central retinal artery, and short posterior ciliary arteries. And it has been found by these equipments that POG patients have been found to be having low ocular blood flow than healthy subjects, low blood flow velocities, lower peak systolic and lower end diastolic velocity in ophthalmic artery, central retinal artery, and they have higher resistive indices in short posterior ciliary artery and retinal arteries in normotensive glaucoma patients. But the problem is that different anatomy is being measured by these equipments, and there is no single blood flow device at present that can simultaneously evaluate all the vascular blood beds which are relevant to glaucoma. And one-time measurement may not be sufficient, and it has to be done for 24 hours. And these imaging techniques have limitations, and none of them is currently accepted as gold standard for measuring optic nerve head blood flow. Current ocular blood flow imaging modalities do not measure structure and blood flow simultaneously. So OCT-based blood vessel imaging is emerging as next step in this dual purpose assessment. These are OCT angiograms. So facts that favor measurement of ocular perfusion pressure in glaucoma are dysfunction of systemic vascular endothelium, which influences progression of open angle glaucoma. Normotensive glaucoma, there is significantly associated with the occurrence of asymptomatic MI. Normotensive glaucoma patients have increased variability of nighttime BP measurements. There is importance of oxidative stress factor and mitochondrial function in OAG, and there is abnormal autoregulatory response to changes in perfusion pressure in patients of open angle glaucoma. Vascular abnormalities extend much beyond the eye. There are in POAG patients, nail fold capillary abnormalities have been found. There are dilated capillaries, avascular zones, hemorrhages. So the patient subgroup in which we should consider the value of assessing ocular perfusion pressure are patients of normal patients of normotensive glaucoma, eyes with disc hemorrhage, patients with progression at low intraocular pressure, patients with hypertension, particularly who are on multiple systemic antihypertensives. There is symptoms of orthostatic hypotension, patients with nocturnal hypotension. So while the relationship between ocular blood flow and glaucoma is relatively well established, nature of this relationship is still not very well understood. Which is more important, IOP or OPP? See, ocular perfusion pressure is a tricky variable. And of the two players in ocular perfusion pressure, we do not know which is really playing the game, IOP alone, BP alone, or combination of both. If it is combination, what is the weight of each variable? So circumstantial evidence of vascular involvement in glaucoma has now been bolstered by experimental evidence and epidemiological study. Vascular theory has not muscled out other theories, but time has come to take ocular perfusion pressure seriously. And OPP is now an established independent risk factor. Time has come to think beyond intraocular pressure, and concept of glaucoma is shifting from a disease of single pressure to a disease of multiple pressure. Convincing correlation of OPP as a risk factor for glaucoma is just like a high-hanging fruit. It is there, but beyond the reach of our present-day evaluation capabilities, and ultimate beneficiaries of work in this area will not be researchers, but our poor glaucoma patients. Thank you, everyone, for your kind and patient hearing.
Thank you, Dr. Balla. Fantastic presentation. As you said, everyone still progresses even when the IOP is well controlled. So definitely there are other factors, and ocular perfusion pressure is definitely the next thing everyone is looking into, detecting this and modifying therapy based on this. We are still a long way towards treatment based on ocular perfusion pressure, but as you said, it's the patient who will be the most biggest beneficiary. Let's all hope that this comes on soon.
Very true. Yeah.
There are no questions from the web platform from the audience yet. We'll proceed to our next speaker's talk, Dr. Neeta KIR. Saujanya, do we have a recording?
Yes, doctor, we have.
Yeah.
I'm Dr. Neeta. Good morning, everybody. I'm Dr. Neeta KIR from Kasturba Medical College, Manipal, and I thank the organizers for giving me this opportunity to speak today. So I'll be speaking on gonioscopy, the right approach to the angle. I have no financial interest to share. There are two types of gonioscopy, the direct gonioscopy and the indirect gonioscopy. Both of them aim to eliminate the total internal reflection that's happening at the anterior cornea or the tear film air interface. I will be first talking about indirect gonioscopy. In indirect gonioscopy, there are once again two types of lenses, the Goldman style lens and the Zeiss style lens. The Goldman style lens is good for a beginner. It stays very well on the cornea once you are placed with a coupling agent. So when you're starting to learn gonioscopy, this is the lens of choice. So once you have mastered the skill of gonioscopy, it's time to move on to the Zeiss style of lens with 4 mirrors. So in this, my personal preference is a Sussman type of gonioscopic lenses, mainly because of its convenience. It's much quicker because we are not using any coupling agent, and the patient's vision also doesn't get as blurred as with a gel. Additionally, there's no need to rotate the lens because there are 4 mirrors and we can view the angles much quickly. Also, there's the added advantage of being able to do indentation gonioscopy, which I'll be speaking about a little later. How do you go about approaching the angle? There are certain things to be done before doing gonioscopy. And first one is to ensure that the intraocular pressure is always checked before doing gonioscopy. Also, do a Van Herrick test when you examine the patient at the slit lamp, because this will give you a clue about what to expect during gonioscopy. In this picture, the Van Herrick grading is grade 4, and in such a case, it is unlikely that the angle will be closed on gonioscopy. In this picture on the right, the Van Herrick grading is 1, and we should be extra careful when you do gonioscopy in this because the angle is most likely going to be closed. Don't forget to explain to the patient what you're going to do so that they will be prepared, and make sure you position the patient correctly. There's this lateral canthal marker on the slit lamp, which has to be aligned with the patient's lateral canthus, which will allow us enough superior and inferior vertical movements. And another important thing to note is that you should have good support for the elbow, otherwise it will be left hanging and you'll soon end up with cramps. And additionally, it's very important that we switch off the room light before we start doing gonioscopy. Light plays an important role in gonioscopy, not just the room light, but also the slit beam, the width as well as the length of the slit beam. Should ensure that the light should not enter the pupil as you do the gonioscopy. In this video, you can see it's a closed angle. None of the structures were visible till I increase the light, the beam width as well as length, and now the light is entering the pupil, and you can see all the angle structures are now visible right up to the ciliary body, and you could have mistaken this for an open angle. How do you go about perfecting the approach to the angle? Read up on the theory, familiarize yourself with the normal anatomy of the eye, practice, especially initially on open angles in normal patients, so that you can identify the short baseline, the trabecular meshwork, the scleral spur, ciliary body band with the iris root insertion. And choose a grading system that works well for you, and also practice documentation of the angle findings. So once you have done with the normal eye, then move on to more trickier cases. There are certain techniques to be mastered when learning the skill of gonioscopy. The first is a corneal wedge, and the next is the indentation or the dynamic gonioscopy. So this gonioscopic photograph will show you that there are two bands of pigmentation, one here and here. You might think this is the trabecular meshwork and this is the ciliary body band. It can be a little confusing for beginners, so that is when we should practice corneal wedge, wherein a thin beam of light is shown into the angle, slightly offset, so that we get a reflection from the posterior corneal surface as well as the anterior, and where they meet would point out to be the short baseline. So this will help us identify the structures correctly. So in the same patient, I go about doing the corneal wedge technique, and you can see reflections from the anterior and posterior cornea. They meet at this white line. So this white line was not the scleral spur, it is the short baseline. The same case, once again, they meet at the white line over here. So whatever pigment was there in front of the short baseline is not the trabecular meshwork. And now when you increase the light, you can see that one pigmented line posterior to the short baseline is the trabecular meshwork. And then there is one more white line after the trabecular meshwork, that is a scleral spur. This would have been misdiagnosed if the corneal wedge technique was not followed. The next is the indentation gonioscopy. So this is an angle that is closed. None of the structures are visible, but we don't know if the angle is closed appositionally or if there is a synechial angle closure. For this, we need to do the indentation gonioscopy, wherein the 4-mirror lens is pressed on the central part of the cornea and the iris is pushed posteriorly, and we can identify the angle structures. Now the angle is open, so this is a case of appositional angle closure. Also, you can see that when the iris is pushed posteriorly, it drapes over the peripheral ciliary processes and the central lens, and you get this double hump kind of a pattern. This double hump pattern is seen in plateau iris configuration. So gonioscopy can be used to differentiate open and closed angles. Like in this case on the left, it's an open angle. All the angle structures are visible. On the right, you can see an angle that is closed with synechia over here. And here you can see the trabecular meshwork and the scleral spur. So this is one of its uses. Gonioscopy is also useful in other kinds of glaucomas too. Like in this case of pigmentary glaucoma, you can see there is dense grade 4 pigmentation uniformly over the trabecular meshwork, with also a sample AC line inferiorly. In neovascular glaucomas, you get to see abnormal vessels that cross the scleral spur and arborize within the trabecular meshwork. In angle recession glaucoma cases, we can get to see this kind of a picture wherein there is a white ciliary body band with a lighter colored ciliary face and a brighter, whiter scleral spur and broken iris processes. This was another case post-trauma. It looked like a regular angle recession, but the patient presented with low intraocular pressure and blood in the Schlemm's canal. So this was a case of hypotonia after trauma. And when we did indentation gonioscopy, we could see that the angle opened up even wider and a large gap had developed between the ciliary body and the sclera. So this was a case of cyclodialysis cleft. It is not normal to see ciliary processes during gonioscopy, but it is possible to do so as in this case of aniridia, wherein a thin stump of iris alone is left behind. In this case of ectropion uvea with neovascular glaucoma also, the iris is pulled away and you can see ciliary processes on gonioscopy. On gonioscopy, we might be able to find the presence of a shunt glaucoma drainage device tube. And in today's era of MIGS procedures, we might see MIGS implants like this eye stent or this hydrus located within the angle. So because of the advent of glaucoma surgeries, minimally invasive glaucoma surgeries, surgical gonioscopy has gained extra popularity. So in surgical gonioscopy, we tend to use more of direct gonioscopy. And for this, I prefer the Swan-Jacob lens. So when doing direct gonioscopy intraoperatively, there are certain adjustments that have to be made to the microscope. The microscope oculars have to be bent about, tilted about 30 to 40 degrees towards the surgeon. And the patient also has to be positioned away from the surgeon. So this allows us to see the angle head on. So this is a view the surgeon gets. And this is a trabecular meshwork. So this is a video of MIG surgery, that is Kahoot dual blade surgery. This is the KDB instrument. And you can see the KDB approaches the trabecular meshwork, digs in and slowly strips away the trabecular meshwork. As the trabecular meshwork is stripped away, you can see this white line developing. That is the direct view into the Schlemm's canal. So the trabecular meshwork is being stripped away. Thank you for your patient listening. I hope this talk has been of some use. Thank you to the organizers once again.
I think that was a great presentation, very nicely covered. Now Dr. Vikram, can you invite the next speaker?
Yeah, we have Dr. Kamala Mahesh. So, Saujanya, can you play Dr. Kamala's talk? She's our co-chairman also for the session.
Sure, Doctor. 2 minutes.
Have there been any questions, Saujanya? Anyway,
No questions, Doctor.
Yeah, you can proceed with the video.
Yeah.
Hello, everybody. So the topic which has been allotted to me today is what to look for in a visual field. So first we have to find out what are we dealing with when we get a visual field printout. We need to find out what are we dealing with, whether it is cataract, whether it is cataract with glaucoma, whether it is plain glaucoma, or we are dealing with a neurological disease or a combination of all the above. So we will be discussing about the interpretation of reports from the Humphrey visual field analysis, since it is the instrument used commonly in the present clinical practice. So when we are looking at the visual field printout, the whole printout can be divided into 11 zones. And as far as possible, we should rely on the full threshold test, as they provide the first real evidence of glaucoma and maybe actually be able to predict a visual loss. So coming to the zone 1 of the visual field printout, so that is the demographic details and which documents the patient's data. So what is important here is you should have the name of the patient for the identity, the age, so that the age adjusted normative database can be relied upon, refractive error, the visual acuity, pupil size. Again, pupil size is very important because we need to maintain the same pupil size in all the subsequent tests also. And the test data which is important is the selection of the test, that is the test point pattern, the test strategy, fixation target, what type of fixation target was used, and the size of stimulus. So all these data has to be entered in the zone 1 of the printout. That is, before we start the test, the machine will ask for all these details, and these have to be diligently entered. Coming to the zone 2 is the zone of the reliability indices. So we have the fixation losses, the false positive and the false negative. Now you should always see the foveal threshold. What is the foveal threshold which is recorded by the machine? And you should correlate the visual acuity with the foveal threshold. So this foveal threshold actually serves as an internal validation of visual acuity, and the two, that is the visual acuity and the foveal threshold, should correspond. That means if the visual acuity is good, but the foveal threshold is low, then there could be early foveal damage. But if the visual acuity is low, but the foveal threshold is good, probably the patient has a refractive error which needs to be addressed. So the patient has to undergo a refraction, and then subsequently the field test can be done. Fixation losses as well as false positives and negatives should be typically less than 20 to 30% for the test to be clinically valuable. And the examiners should also look for the numbers printed in the numerical result, that is in the decibel values. And a value of 40 decibels or higher on this graph is indicated as a trigger happy patient. Now coming to the zone 3. So zone 3 is the zone of the raw data. So it actually gives the exact retinal sensitivity of the patient, where 0 indicates an absolute scotoma, and this could be strategy specific. The same strategy should be used in subsequent tests also. So less than 0 or 0 is absolute scotoma, and if it is less than 1, it is probably a dim bulb and needs clarification. Change, calibration and change. So coming to the zone 4, that is the gray scale. So grayscale, actually, we never make a diagnosis based on the grayscale. In some instances, it highlights the area which we have to look for in detail. Like, for example, in this grayscale, so you have this some activity going on here. So we go back and see all the numerical data and the deviation plot. So we know that we need to concentrate on this particular area. However, we don't take it as a, the main thing for diagnosis on the HFA. And it is also helpful when there are high false positive and false negative results. For example, if it is a trigger happy patient, you will have a white scotoma. And if it is if the patient has not been cooperative, and you may have a clover leaf pattern also. So the grayscale will give this information. Now coming to the total deviation plot, the zone 5 and the zone 6. So basically you have the a numerical value and the statistical interpretation. So it is actually a point-by-point difference of the patient's threshold from those expected in the age-corrected normal. So total deviation plots actually suggest the overall sinking of the heel of vision. Usually this is caused by media opacities like cataract, corneal opacity, refractive error, or meiosis. However, this is a generalized depression and it does not reveal any hidden scotoma. So if you have to take an analogy of this, it will just tell that what height is the road above the sea level. So that is all the information it will give. Now coming to the other points in this is the value of 0, that is deviation. Zero deviation indicates the measured retinal sensitivity and the normative data are at the same level, that is there is no loss of sensitivity. If the deviation value is with no sign, it indicates that the retinal sensitivity is better than the normative data. And if the deviation comes with a negative sign, that means the retinal sensitivity is worse than the normative data. Therefore, there is a loss of sensitivity there. Now coming to the pattern deviation plots. Pattern deviation plot actually represents the focal depression areas in the points tested when accounting for the overall depression at the estimated by the mean deviation plot. So that means what? It shows the localized scotoma hidden inside the total deviation plots. That means after getting to know what is the height of the road above sea level, now the pattern deviation plot actually is telling you the size of the potholes in that road. So basically in the generalized depression, the pattern deviation plot gives the localized depression. Now coming to zone 9, that is the global indices. So basically it is the statistical manipulations providing the total and pattern standard deviation plot, which are point-to-point calculations. And all these points are reduced to a single value that provides the examiner information about the patient's field. So mean deviation is an average difference from the normal expected value in the patient's particular age group, whereas pattern standard deviation provides information about the localized loss. A high pattern standard deviation indicates a non-uniform sensitivity and a localized scotoma. Coming to the zone 10, that is the glaucoma hemifield test. So the hemifield test actually compares points in the upper field to the corresponding points in the lower field and then interprets the results. So you can have 5 types of results in the glaucoma hemifield test, which could be borderline, outside normal limits, abnormally low sensitivity, abnormally high sensitivity, and within normal limits. Coming to the zone 11 or the gaze tracking. So if you see the last bit of the field, you will have these lines which are there. So what was this line means? If it is too much above, so just remember that's a big movement of the eye, which is not good. And if there are very subtle lines which are just seen very, very close to the line, then remember that it's a good steady fixation. And the blanks which are there is also okay. But however, if you see the second graph here, there is a lot of variation in the gaze. So that means this patient has not been fixating properly throughout the test. Now, once we have all this knowledge, we need to apply the Anderson's criteria for glaucomatous field defect. So these criteria, especially in the Humphrey printout only, are helpful in the diagnosis of early glaucoma, and they are as follows. So you have to take an abnormal GHT, 3 or more non-edge points of the 30-2 printout, contiguous and with a P less than 5%, out of which at least one has a P less than 1%. And a corrected pattern standard deviation should be abnormal and should have a P less than 5%. So let's take some examples here. So if you see the patient data is there, and then of course it's been hidden for privacy purposes. And here if you see your reliability indices, they seem to be good. The grayscale looks relatively normal, so we really don't have any pain point here probably. And then if you see the raw data also does not show any major deviation or fluctuation from the retinal sensitivity, normal retinal sensitivity. However, there are some depressed points in the total deviation plot, which is showing up in the numerical value is showing up in the plot as well. So in both the eyes, it is the same. However, if you see the generalized depression and if you see the focal depression in the pattern deviation plot, actually you don't see anything which is continued into the pattern deviation plot. So probably this patient is a pure cataract, and more so patient has a posterior subcapsular cataract, because if you see the depression is more at the center. So this patient could be having a PSC. Now this is a second case where if you see the grayscale, it shows a superior arcuate scotoma. And if you see the total deviation plots, there are statistically significant points which show that there is decreased retinal sensitivity. And the same continues in the pattern standard deviation plot also, though it looks less than the total deviation. So probably this patient might be having cataract with glaucoma. So that means the total deviation plot has been it is reduced. I mean, the sensitivity is reduced because of a generalized depression, and at the same time there is a significant localized depression in both the eyes. So probably the patient has cataract or a refractive error with glaucoma. So if the refractive error was not corrected, so probably it could be either cataract or cataract or refractive error with glaucoma. Now coming to this kind of a field. So here if you see, you can see that the field defects are respecting the vertical meridian. So this is what we have to remember, that the glaucoma fields always respect the horizontal meridian, whereas the neurological fields, they respect the vertical meridian. So in vertical meridian, we apply something which is called as RP Mills criteria. So for subtle hemianopic defects, which are suggestive of a neurological disorder, they must be looked at the end of all field interpretation. Otherwise, it may be misinterpreted as a very early glaucomatous defect. So for this purpose, one should analyze the raw data and look for the following points, like, the 3 criteria which are there. So the first thing is you have to compare the decibel values of the adjacent rows on either side of the vertical meridian. So at least 3 adjacent pairs should show unidirectional difference in the sensitivity. That means if you check these rows, if you check the rows of 2 adjacent points along the midline, there will be some unidirectional difference in the sensitivity. And corresponding pairs in the next column, adjacent to the first column, also should show difference in the sensitivity in the same direction. So that is how it goes. The whole, if you see the midline, there is a difference in the sensitivity, which is moving in the same direction. And at least a difference of 2 decibels is significant in suggesting a early hemianopic defect. So if you apply the RP criteria, you can find out the hemianopic defect. So in this case, the patient is having a right homonymous hemianopia. This is a similar neurological field because it is respecting the vertical meridian. RP criteria is applied, and then you can make out that it is a hemianopic defect. So it is in the it is a binasal hemianopia. Now, in these tests, if you see the right eye, definitely there is some activity here. In the grayscale, you see the sensitivities, it is reduced, and you see the total deviation plot and the pattern deviation plot. Definitely, you have the defects which are moving on, which is persistent in the both the plots. So definitely there is some glaucomatous activity going on in the right eye. And in the left eye, if you see, the activity is more at the nasal step of Rowan. So if you apply the Anderson's criteria to this, there will be, it will be proved as glaucomatous defect. Of course, you have to correlate with the clinical signs. Now, this is a 10-2 printout where you can see that the scotoma is abutting at the fixation. So this is the macular split. So macular split is defined as at least one point out of the 4 points which are abutting at the fixation, which has to be less than 10 decibels. So that is the macular split. So this is in an advanced glaucoma where you have the macular split. And also you have to remember that whenever you are dealing with these cases, there may be multiple problems in the same individuals. Like I told that you may be handling a cataract, a glaucoma, a neurological field in the same patient. So you have to be extremely careful in what you are diagnosing. Please take proper history and correlate with the clinical findings. At times what happens, even vein occlusions also give arcuate defects. So you need to be extremely careful before labeling a patient as glaucoma, and you have to take all the ancillary tests into view before you actually base the diagnosis on the patient. So be extremely cautious and always interpret these tests along with your clinical diagnosis and with the interpretation of the other tests as well. So thank you very much, Coscon, for this opportunity given. Thank you, Dr. Ellen and Dr. Shibi, for having me around here. Thank you and all the best for the rest of the conference.
Thank you, Dr. Kamala. I think Dr. Asha is logged in. We'll go on with Dr. Asha's presentation next. Sajjana, can you play Dr. Asha's presentation?
Yes, Doctor. Sharing.
Do we have any more speakers who have logged in after Dr. Asha? I don't think so. So we'll have a discussion after Dr. Asha's talk.
I would like to thank the Scientific Program Committee convener and members of COSCON 21 for giving me an opportunity to talk on this forum. I will be covering why, how, and what to look for in the clinical evaluation of the optic disc. We all know that glaucoma is a chronic progressive optic neuropathy that is associated with the corresponding visual field defect. So the evaluation of the optic disc is very important in the diagnosis and management of glaucoma. It also helps in quantifying and monitoring the change over a period of time. So optic disc is the most important marker in the evaluation of glaucoma. Why? Because 30 to 50% patients have normal IOP at first visit, and not all ophthalmologists have access to perimetry and other diagnostic equipment. And even if they have, it is difficult to interpret and requires a learning curve. So optic nerve head evaluation, though it is subjective, it is very important in diagnosis and monitoring of glaucoma because the structural damage is the first to occur in optic nerve head. How do we examine optic nerve head? Always examine with pupils dilated. If there is angle closure, do PI and then dilate. Use red-free filter to see the details clearly. Optic disc evaluation can be done on slit lamp biomicroscopy, direct ophthalmoscopy. Indirect ophthalmoscopy also helps in overall view, and optic disc photography helps in documentation, monitoring the progression. Direct ophthalmoscope is the commonest used. It gives an virtual upright image and gives 15 times magnification. It gives monocular clues about the disc size, contour, cupping, and pallor, and nerve fiber layer. But the disadvantage is it has no stereopsis and too large an image is seen. Slit lamp technique using 90D and 78 diopter is easy to use. It gives a very good stereopsis and gives inverted real image. Anatomy, about 1.2 million ganglion cell axons are bending and going into the fenestrated scleral canal with 1,000 bundles supported by astroglia. And these develop myelin sheath behind the sclera. So the main pathology is in the lamina cribrosa. Due to the mechanical and vascular etiology, the changes in glaucoma occur at this lamina cribrosa. The most important parameters to look for are disc size and shape, neuroretinal rim, cup, optic disc hemorrhage, nerve fiber layer defect, parapapillary atrophy, vascular signs. And these can be summarized in 4-3-2-1 system. That is, outside in the scleral ring, we see peripapillary atrophy, disc size, disc shape, disc tilt, and inside cup depth, cup rim, cup to disc ratio forms within the scleral ring, and confirmation is got by retinal nerve fiber layer, disc hemorrhage, and finally we come to a conclusion whether it is glaucoma or not. So optic disc size, the size of the optic disc is very important. Size and shape are very important to know the difference between the physiological cupping and pathological cupping. We all know that large discs have large physiological cups and small discs have small cups or no cups. The mean disc size varies between 1.5 to 2.2 millimeter in diameter. Anything more than 2.2 is considered as large, and less than 1.5 is considered as small disc. How do we measure this optic disc size? By grossly, it can be measured by direct ophthalmoscope, where Welschalin direct ophthalmoscope is used. The 5-degree aperture gives the average optic disc size. In a slit lamp biomicroscopy, different lenses are used to see the disc. The narrow slit is measured between the superior and inferior rims, and the scale reading on the slit lamp is seen. This is multiplied by the multiplication factor used for various types of lens. So depending on the disc size and shape, different patterns of the disc are given, like focal ischemic disc, scleral disc, concentrically enlarged disc, myopic disc with glaucoma. Though these are not very important, it is better to know these types of discs. Cup is the excavation in the optic nerve head. It is related to the disc size. Always compare the cup with the disc size. So vertical cup disc ratio is usually measured. In normalized, horizontal CD ratio is more than the vertical CD ratio. In glaucomatous eyes, vertical CD ratio is more than the horizontal CD ratio. Mean CD ratio is about 0.4. In about 5%, it may be more than 0.7. Cup to disc ratio seldom exceeds 0.2 in the same eye. Then asymmetric between both eyes of more than 0.2 occurs only in 1 to 6% of normal population, but in 24% of patients with primary open angle glaucoma. We should always be careful while seeing the small disc, because early and moderate glaucomatous damage may be missed because of the low cup disc ratios. The mean cup disc ratio can vary between 0.26 in a small disc less than 1 millimeter to 0.55 in a large disc more than 2 millimeter. The neuroretinal rim is the most important in the diagnosing glaucoma while seeing the optic nerve head. It is defined by the disc margin on the outside and the cup margin on the inside. The isn't rule is followed in normal optic disc, where the nerve fiber is very thick at inferiorly, followed by superiorly, and then nasally. The last is the temporal, which has the thinnest neuroretinal rim. So when there is loss of these axons, the neuroretinal thinning occurs in a sequential pattern. It can follow inferotemporal, superotemporal, horizontal temporal, infranasal, or and then supranasal. In contrast, in the non-glaucomatous optic nerve damage, the NRR is not always affected, and hence contour of the NRR is maintained. Focal notch is a localized defect in the neuroretinal rim on the cup side of the rim. The acquired pit of the optic nerve is a localized loss of tissue immediately adjacent to this outer edge of the rim. It is usually located slightly temporal to the superior or inferior pole. Coming to disc damage likelihood scale, though this is not very important, but in research work it is used. It is based on the radial width of the neuroretinal rim measured at its thinnest point. Unit of measurement is the rim by disc ratio. When there is no rim remaining, the rim disc ratio is 0. The circumferential extent of rim absence is measured in degrees. So it is staged into, it has 10 stages. 1 to 4 is considered as disc at risk. 5 to 7 is glaucoma damage, and 8 to 10 is glaucoma disability. The color of the neuroretinal rim is very important. In normal, the cupping will be equal to the pallor. In glaucomatous damage, cupping will be more than the pallor, and in non-glaucomatous, cupping is less than the pallor. When we see pallor more than the cupping, then we should think about angle closure glaucoma, where there is ischemic etiology or neurological disc. Optic disc hemorrhage is very important, though it is considered as hallmark of glaucomatous damage, optic nerve damage. It is also seen in other conditions. It is located usually in the inferotemporal and supratemporal disc margins within 2 clock hours of RNFL defects. Usually cross disc margin and papillary portion disappear first. It suggests progression in glaucomatous eyes, and it is more common in normal tension glaucoma. These are optic disc hemorrhages seen. And cause of this optic disc hemorrhage, the hypothesis is suggests that the rapid deterioration of the rim tissue and development of rim notching cause stress on the microvasculature, resulting in disc hemorrhage. Coming to retinal nerve fiber layer, it is the retinal ganglion cell axons covered by astrocytes and bundled by processes of Muller cells. It is seen as bright, fine striations spanning off from the disc to the periphery. It is well seen in dilated pupil with green light. The defects are may be considered into localized RNFL defects and diffuse defect. Localized is can be seen as slit-shaped or wedge-shaped defects arising from the superior or inferior poles, and these appear as dark stripes. These can be detected before the visual field defect developed. Diffuse is difficult to see. It is peripapillary retinal vessels appear bare, and underlying choroidal vessels are more clearly seen in diffuse loss of RNFL, like this. Coming to parapapillary chorioretinal atrophy, it has 2 zones, central beta zone and peripheral alpha zone. Central beta zone is considered to be more seen in glaucomatous eyes than in normal eyes, yet not very sensitive or specific enough to be important. The vascular signs can be seen as bionetting sign, wearing of the circumlinear vessels, and overpass cupping, not very important. And we should give more importance to the exit of the central retinal vessel trunk on the lamina cribrosa. The longer the distance to the central retinal vessel trunk exit, the more marked the neuroretinal rim loss and visual field loss. Retinal artery attenuation can be either diffuse or focal attenuation. Diffuse is associated with increased visual field defect, and focal attenuation is more common in normal tension glaucoma. So this is focal retinal arterial attenuation and diffuse retinal arterial attenuation. So with all these, the most important variables to diagnose preperimetric glaucoma, but just by looking at the optic nerve damage, we should remember shape of the neuroretinal rim, size of the cup in relation to the optic disc, diffuse or focal RNFL defects, and disc hemorrhages. So take home message would be always check for the disc size and see the ask the family history. Check for neuroretinal rim, apply isn't rule, look for nerve fiber defects, correlate with visual field defects, look for asymmetry of the disc and also the pallor of the neuroretinal rim. Make sure it is not an ACG or neuro defect, and document serially. This is very, very important. Document serially either by a drawing or photography. Thank you so much.
Thank you, Dr. Asha. Nice presentation. I think we'll move on to discussions and then go back and play the other talks of the speakers who are not present. Question for Dr. Tanushree. What method of tonometry do you use on a routine basis for every single patient?
Yes, sir. Actually, in OPD, we screen almost all the patients with rebound tonometry.
Rebound
And
tonometry, yes.
yeah, we use the rebound tonometry. And for glaucoma follow-ups, I do explanation for each and every patient.
During the peak of COVID, did you shift from Goldman to rebound eye care for the glaucoma patients too?
Yes, sir. Actually, in the initial days, but again, yeah, most of the patients I did rebound tonometry.
I think all of us had done that at that time when the peak was
Yeah.
going on. We had stopped doing application for anybody and everybody, and we were relying on the eye care tonometer. Eye
Yes,
care
sir.
does have its place in situations like this where Goldman you're scared to do, and also it's much more less cumbersome. And I was happy that you had mentioned, put one slide there which shows that eye care is acceptable to be done on a routine basis in non-glaucomatous patients as a screening device.
Yes, sir.
I don't think Dr. Balla is there. Dr. Kamala, visual fields in
Yes,
patients
Vikram.
who do not perform it very well, you're
Yeah.
seeing very poor reliability on a long term. Let's say 4 or 5 times you've done it. Do you
Correct.
still try to do it? Because that is one dilemma we always face, whether we
Correct,
subject them
correct.
to 30 minutes of
Absolutely.
yes,
So
yes.
that's a practical difficulty, Vikram, which you have correctly pointed it out. What usually happens is, like the speaker said about the optic nerve evaluation. So in that
Yes.
situation, we need to rely more on the optic nerve evaluation. Look
Yes.
for all the signs of glaucoma. That there is where your bearing of the circumlineal vessels, the peripapillary atrophy, and your alpha beta zones, everything you need to really look very, very carefully. And of course, IOP will be the guiding light here, the guiding angel, whether you have to start the medications or not. But
Depend on IOP and field on and optic nerve head.
You cannot just write off what do you say, non-reliable field. You cannot just say that it's bad. So, you should try to take some kind of information which comes out of that non-reliable field as well. So if your clinical examination, you have done it very, very minutely, probably you should be able to correlate something out of that. Probably there will be some superior arcuate like defect, unless it is a grossly unreliable field, like say a trigger happy patient or a patient who has slept off during the test. So you should try to make out something which is useful from that field. But most of the times what happens is counseling does help. I mean, you should tell the patient as to what to do. You can give a trial run of the field instead of taking the final printout.
Yes.
Saying that, this is what I'm going to take. You can give a trial run. Of course, you need a very, very patient technician, a patient OPD, and all these things come into play. But then what I usually do is I don't really write off a non-reliable field saying that, I'm not going to do anything. This is not helpful for me clinically. Some information does come out of that.
Yeah, looking at the grayscale, you do get some information.
Correct. Something will
One more
come
thing
out.
that I do is I try to call them at 9 in the morning. First thing in the day, if they do the fields, the reliability is generally better.
True. Or you can probably offer them a cup of coffee or tea, and that also improves the performance. They don't tend to sleep. Or it's a dark room, nobody is talking. So it's very easy to doze off there. So all these things come into play.
Thank you. Dr. Neeta, once you label either a disc suspect or a patient with glaucoma as having open angles, do you repeat the gonoscopy later on during follow-up? If so, how often?
I do repeat. I try to repeat at least once a year in an open angle glaucoma. Am I audible?
Yes, perfect.
Yeah, I try to repeat at least once a year. because it is possible that a person who is open angle glaucoma can change over to a little bit of angle closure component when the lens thickness increases with age. So yes, we should repeat gonioscopy over time.
True. Even I practice that around once in 6 months to a year, depending on the patient follow-up. We always have to repeat it and tackle it accordingly. Any other questions from Dr. Kamala?
Nothing really much. I would like to just discuss with Dr. Neeta, like say a fresh person who has just finished their fellowship and all those things. What are the tips you will give for what do you say, a perfect gonioscopy to a freshly passed a fellowship graduate?
I said practice more and more. Actually, every patient you get, you can try practicing gonioscopy, even in the normals.
Yes.
And try different magnifications, different illuminations, try everything possible.
Correct. And what would you recommend as a choice of lens for these fresh graduates?
I think once you're in a glaucoma field, you should be using more of the 4-mirror, which can, indent.
Correct.
Do the indentation. Don't
Absolutely.
go back to Goldman. Maybe Goldman type is good for photography. That's what I realized when making the presentation. For photography, the Goldman type is very, very good.
Yeah, yeah. Yeah, absolutely. Because many of these fresh graduates, they're struggling with the 4-mirror lenses. So even the same thing, so you have to tell them that you have to get hands on the lens and keep practicing it often.
Yes.
Yeah, absolutely, Neeta. Thank you.
Thank you.
Yeah, Saujanya, I think you can go ahead and play the next presentations, although the speakers are not there for unavoidable reasons, I guess. Saujanya, can you play the next recorded presentations? Yes.
At the outset, I would like to thank Coscon for making me part of this. The topic allotted to me is approach to a glaucoma suspect. I am Dr. Vidya Devi from Optic Hospital. Is it important to diagnose any patient as glaucoma suspect? Yes, because you have to distinguish a healthy person in a general population who are at increased risk of developing glaucoma. And these are referred to as glaucoma suspect patients, because you have to decide whether these patients have to be followed up or treated prophylactically. By definition, any open angle on gonioscopy with one of these following features, having intraocular pressures of more than 21 millimeters of mercury, with some disc or retinal nerve fiber changes, or having some rim changes as diffuser focal narrowing or sloping, with some RNFL changes which are either diffuse or localized, or if you see some disc hemorrhages, or if there is disc asymmetry between two eyes of more than 0.2, or if they're having any field changes, you subject them as glaucoma suspect. It is said that on the basis of elevated IOP, the rate of progression of chronic open angle glaucoma is 1% per year over 5 to 15 years over 5 to 15 years. Therefore, these patients have to be followed up very carefully for prophylactic treatment. Another set of high-risk glaucoma suspect patients are if they're very older age group, or if they have CD ratio of more than 0.7, or if their intraocular pressures are consistently high, more than 30 millimeters of mercury, or if they're having some thin corneas or some field changes which are suspicious of glaucoma. You can also see some changes within their anterior segment as exfoliations, or if they have some family history of glaucoma, or their other eye having some unilateral glaucoma, with additional factors which can be in the form of ocular as suspicious disc, high myopia, or if they're steroid responders, or they can also have some systemic risk factors such as diabetes mellitus, hypothyroidism, headache, and vasospastic disorders. AOI has given some guidelines whether to treat these patients or not, or to be followed up. If these patients come to you as glaucoma suspect, these patients should be examined every 6 months for 2 years. And when they come, you should always do their optic nerve head analysis as well as their visual fields every 6 monthly. And if they come under a high risk group, that is second one, these patients should be examined every 3 monthly, and they should be subjected for optic nerve head evaluation and visual fields every 6 monthly. If these patients are diagnosed and treated as glaucoma and they're achieving some target IOP and they come under high risk category, these patients again to be followed up every 3 monthly, and every 6 monthly they should be evaluated for their optic nerve as well as visual fields. And in case you don't achieve their target IOPs, these patients should be followed up every 4 monthly, and every 3 monthly you should do their fields as well as optic nerve head analysis. And whenever they come to you, you should have good baseline documentation. You have to see for some changes, if they're seen in the form of intraocular pressures or field changes or optic nerve head changes, because it will basically tell you whether they have some structural or functional damage. You should always measure the intraocular central corneal thickness, because it is said that if they have higher CCTs, then they come under category of glaucoma suspect, and it is said that greater than 585 micrometer central corneal thickness is seen in 42% of glaucoma suspect patients. So when you do their examination, you should always concentrate on excluding their secondary causes for glaucoma, wherein you do gonoscopy and try to rule out angle closures, recession, pigment dispersion, or some inflammatory cause. And you have to look into their angle structures. You should also evaluate their fundus to look at their some disc changes, which may be in the form of subtle hemorrhages, which will eventually lead to field loss as well as structural damage. It is always important to document if they have some retinal nerve fiber layer defects, and these are usually got in your red free light. If it is, if you want, they can also augment seeing them by using either scanning laser ophthalmoscopy or OCTs. Visual fields are usually done for these patients, and whenever you do visual fields for these patients to diagnose them as glaucoma suspect, minimum 2 to 3 baseline fields are must for these patients, and usually 30-2 is enough for them. In case you diagnose them as glaucoma patients, the preferred options are 24-2 CETA standard, or you can do 24-2 full threshold, or FDT matrix swab can be done for these patients. Now you have to make decision whether to treat these glaucoma suspects with raised intraocular pressure or no. Once they come to you, you have to stratify these patients into low group, moderate group, or high risk group for progression of glaucoma. This is usually augmented by your clinical judgment as well as your available gadgets. And these patients are subjected as high risk. If they come under the category of high risk, you should start treating them. And if they come under moderate risk, then you have to monitor them closely, or you can start treatment for them. If they come under the low risk category, you have to monitor their intraocular pressure changes along with their structural changes in the optic nerve head and functional changes in order to know whether there is progression of glaucoma. Once you start initiating the treatment, some factors have to be included in treatment, like greater age group, life expectancy, psychological factors, some convictions between patients and physicians, some environmental factors, and whether they will be able to follow up, and some consideration should be given if the patient is a pregnant lady. When you follow these patients, you should always look for whether the patient is already receiving a medical therapy or his target IOP is reached or no. And this should be done at least 6 to 12 months, so 12 monthly, and this should be done more frequently in high risk patients. At each visit, you should and must do their intraocular pressure measurement and gonoscopy should be repeated always. And you can document their optic nerve head changes, and field tests can be done every 6 monthly and compared with the baseline. The summary is the physician should document good baseline data to have a benchmark to assess whether the patient will progress to glaucoma, and CCT is must if you think that patients are at risk of developing glaucoma. It is important to stage any patient into low, moderate, or high risk glaucoma suspect. And whenever you start initiating a treatment in glaucoma suspect patients, things should be considered are his systemic factors, his ocular factors, psychological factors, and social factors have to be taken into consideration once you start initiating treatment. Thank you.
Saujanya, will you play the next presentation before we wrap up?
Sure, doctor.
Good morning, everyone. Thank you for the KOS for giving me the opportunity to talk in this conference. Thank you, Dr. Elankumaran sir and Dr. Shibide for giving me the opportunity to talk in this conference. Today's my topic is angle closure glaucoma classification. So why is it important? According to the 2020 global estimate, the 20 million people are having primary angle closure glaucoma, and the ratio of primary angle closure glaucoma to open angle glaucoma is 1:3. But the ratio of blindness because of the angle closure to open angle glaucoma is 1:1. Primary angle closure glaucoma carries threefold excess risk of severe bilateral visual impairment or blindness versus primary open angle glaucoma. What is primary angle closure glaucoma? So normally the aqueous humor is secreted by the ciliary process of the ciliary body. It flows from posterior chamber to anterior chamber through the pupil and flows out of the eye through the trabecular meshwork. In angle closure glaucoma, the angle of the anterior chamber is blocked physically by the iris, causing angle closure to happen, causing increase in intraocular pressure, causing the optic disc damage and the visual field damage. In open angle glaucoma, on gonoscopy, all the structures of the anterior chamber angle can be nicely seen. In closed angle, none of the angle structures will be seen. The anterior segment OCT also shows the wide opening of the angle, and in the angle closure, the angle is blocked physically by the iris. Why does angle closure occur? The key features for the angle closure to occur is the iridotrabecular contact, reducing the drainage of the aqueous humor, causing increased IOP. So the pathophysiology is mainly the relative pupillary block, plateau iris, and the exaggerated lens wall. In physiological pupillary block, large area of iris comes in contact with the anterior surface of the lens. Then there is a resistance to aqueous flow from posterior to anterior chamber, causing relative pupillary block. The pupil dilates, peripheral iris becomes more flaccid and pushed anteriorly. When it is mid-dilated position, according to the Mapstone theory, the lateral forces of the sphincter and the dilated muscles cancel each other. The posterior vector force becomes maximum, pushing the iris anteriorly. The iris comes in contact with the trabecular meshwork, causing the blockage of the aqueous humor to flow and causing the increase in intraocular pressure. The predisposing factors are anatomic factors like shallow anterior chamber, short axial length, smaller corneas, thicker iris, thicker lens, and anteriorly positioned lens. Physiological factors like dim light, accommodation and near work, stress, Valsalva, mydriatic induced in the clinic. How to classify the primary angle closure disease? Patients with primary angle closure disease were earlier classified depending on the symptoms: acute angle closure glaucoma, subacute angle closure glaucoma, chronic angle closure glaucoma, and the combined mechanism glaucoma. In acute angle closure glaucoma, the symptoms are sudden and severe with marked pain, blurred vision, and the red eye. The patient may also have nausea and vomiting. In subacute angle closure glaucoma, it will have same pupillary block mechanism as the acute form, but the symptoms are mild or absent. Also called as intermittent, prodromal, and the subclinical. Patients with subacute angle closure glaucoma may have repeated attack before going for acute angle closure glaucoma or chronic angle closure glaucoma. In chronic angle closure glaucoma, the portions of the anterior chamber angle is permanently closed by peripheral anterior synechiae and the IOP is chronically elevated. The synechial closure may result from prolonged acute attack or repeated subacute attack of angle closure glaucoma. In combined mechanism glaucoma, in some eyes, the glaucoma appears to have both open angle and the closed angle mechanism. The diagnosis is made after an acute attack of acute angle closure glaucoma attack in which the IOP remains elevated after the laser peripheral iridotomy despite an open normal appearing angle. The newer classification, the current classification of primary angle closure disease is based on the International Society for Geographical and Epidemiological Ophthalmology. It is based on the natural history of the disease. Primary angle closure disease can be divided into primary angle closure suspect, primary angle closure glaucoma, acute attack of the angle closure. In primary angle closure suspect, there is a iridotrabecular contact of more than 180 degrees. There is an occludable angle, but there is an absence of peripheral anterior synechiae. There is no increase in intraocular pressure. There is no disc changes or the field changes. In primary angle closure, the iridotrabecular contact is more than 180 degree. There is a presence of peripheral anticyanic may or may not be associated with intraocular pressure. On gonioscopy, we can also see the pigment clumps on the trabecular meshwork. There is no disc changes or there is no field changes. In primary angle closure glaucoma, there is a iridotrabecular contact of more than 180 degree, presence of peripheral anticyanic, there is increase in the intraocular pressure causing the disc changes and the field changes. In acute attack of angle closure, because of the pupillary block, there is a sudden closure of the angle leading to sudden increase in the intraocular pressure. It does not terminate on its own. It's a sight-threatening condition. So, occludable angles is equal to primary angle closure suspect. When primary angle closure suspect is added with evidence of angle closure, that is peripheral anticyanic, it is called as primary angle closure. When primary angle closure is associated with increased in intraocular pressure, it is called as primary angle closure with ocular hypertension. When PAC with ocular hypertension is associated with optic nerve damage or the visual field changes, that is called as primary angle closure glaucoma. Coming to history and examination, family history of the acute angle closure glaucoma should be asked. History of any drug-induced, especially anticholinergics and antidepressants, which causes the pupillary dilatation, causing the angle closure. And sulfonamide drugs like topiramate and desidezolmide cause a idiosyncratic reaction, causing the secondary angle closure glaucoma. Symptoms are colored halos, pain, redness, headache, unilateral blurred vision, and the vomiting in the acute cases. The signs includes a shallow anterior chamber, that is on pen torch light, you can see the eclipse sign, and the loss of pupillary rough. The Van Herrick's will be 1 or gradings 1 or 2, and on gonioscopic, the none of the angle structures will be seen. In acute angle closure attack, there is a circumcorneal congestion, corneal edema will be there, anterior chamber will be very shallow, pupil will be mid-dilated, fixed, not reacting to light. The findings suggestive of previous attack of acute angle closure glaucoma includes peripheral anticyanic, post-cyanic, glaucoma flecans, sector or generalized iris atrophy, optic nerve cupping, and or pallor and visual field changes. Whether special investigation is like UBM and ASOCT is required to detect the angle closure disease? Usually no. So most of the time, primary angle closure disease is detected by the clinical examination. In some cases where there is a iris cyst, plateauiris, and drug-induced conditions, the UBM and ASOCT may be required to detect the primary angle closure disease. Provocative tests like darkroom provocative test and mydriatic test. There is no role of provocative test in primary angle closure disease. Provocative test causes it provokes the angle crowding, and there will be increase of pressure about 8 mm of mercury, and identifies those likely to develop primary angle closure disease. Negative test does not rule out the angle closure, but can put the patient at risk for acute attack. Management of primary angle closure disease includes the laser, lens extraction, and the filtering surgery. It will be dealt in detail in the next session. Thank you so much.
With that, we come to an end of this session. We won't be discussing these last two talks, fantastic talks, since the presenters are not present in the session. With that, I hand over the hall to Dr. Shailesh, moderator of the next session.